That was talking about the environment.
Yeah.
Then to combat inflammation.
Yes, okay.
So another
couple of slides here, again, just addressing that issue. So as I've already said, there are a number of downstream effects of the inflammatory response in the lung. So we mentioned increased reactivity, mucus hypersecretion, recruitment of neutrophils, airway remodeling, and bronchospasm. But they all seem to have their root at the inflammatory response within the lung. So it makes sense to combat that. And the use of corticosteroids would be the mainstay therapeutic approach, certainly to human asthma as well, but also to equine asthma. With regard to pros and cons of different approaches, there are a number of different routes that potentially could be used. There could be a parenteral administration of drug through intravenous medication or intramuscular medication, the feeding of corticosteroids in feed. Certainly, there's been a number of studies looking at the efficacy of that approach, and then a lot of interest in the use of inhaled corticosteroids. And they all have their advantages and their disadvantages. I would say the biggest advantage of the enteral route would be convenience, that it's convenient to feed steroids in the feed of the horse rather than spending time, nebulizing the horse. But we don't have to just consider convenience, we have to consider efficacy as well. And then we also have to consider the potential benefits of the inhaled approach, which theoretically would be that you're delivering drug directly to where it's required. Inflammation's in the lung, it's not anywhere else, it's in the airway. So delivering that drug to the site of inflammation makes a lot of sense. And also it limits systemic exposure to the drug. So theoretically, there should be less opportunity for that drug to be absorbed systemically, resulting in some of the perhaps unwanted effects of that particular drug. The potential, one thing that's worth knowing, I think, is with regard to delivery. Now, this was work that's quite old now. This is from Dominique Vauchan in '98, and this was looking at, this is a scintigram of a horse that was being administered labeled fluticasone, so technetium labeled fluticasone, looking at the deposition of that particular drug within the airway. And red is high deposition, blue low deposition. So we can see there that a lot of that drug that's administered by inhalation ends up in the nares, and that's no different to people as well. A lot of the drug will end up in the oropharynx, when with people that are taking MDI. So as long as we're aware of that, then that's important. One could argue that, well, if you know most of it's ending up there, you just give a little bit more drug to make sure that you get the desired concentration lower down. Do
you know what the reason for it ending up there is? Is that the mode of action of the inhaler or the particle size, or...?
I think with MDIs, it's probably not related to particle size because they have a fairly homogeneous output with regard to their particle size. The propellant, certainly, this is one of the reasons why we use spacers in horses, that we can't expect to get good deposition in the lung if we just administered an MDI directly into the horse's nose, because it comes out under pressure, and when it comes out under pressure and high velocity, then it'll just impact within the nares. So certainly with MDIs, that's one concern. It may well be related to the breathing pattern of the horse, or it may well be that the upper airway is doing what it's intended to do. It's intended to protect the lower airway with regard to things that are inhaled, and it's a case of trying to get over those mechanisms in order to allow us to deposit drug in the lung, and I think we really just have to accept that a lot of it does end up in the upper airways. But certainly we get therapeutic levels down in the lung, and that's been clearly shown with the use of a number of inhaled steroids in horses that have proven efficacy against equine asthma. One other point, really, with regard to the use of MDIs. This is some work that we conducted in Edinburgh, and we're quite keen to compare the particle size deposition of MDIs up in the top here. So basically this is a piece of equipment called a next generation impactor. So the further along we come along this piece of equipment, so this is where your airflow is running through these different stages. The further along here we go, then that represents lower and lower in the airways, so progressively narrowing airway caliber. And we're looking to get deposition roughly around this kind of level here, around sort of stage 4. And then we're just using a kind of commercially available spacer device where we're using an MDI and we're comparing it to a mesh nebulizer. And the MDI did kind of what it says in the tin in that it produces particles in the respirable range. They're sitting just exactly where we want them to get to. But the slightly concerning thing was this coefficient of variance of 45%. So these were 10 episodes of 10 sequential repetitions or actuations of the MDI, and we can see that the variability in deposition within a laboratory environment, and then you transfer that to a horse, then that's probably going to be as, if not more, variable. And then the mesh nebulizer, well, it's probably an unfair comparison here because ultimately the deposition of particles from a mesh nebulizer is going to be dependent on the pore sizes within the mesh. So if there's a heterogeneous population of number of pore sizes or size of pore sizes, then it's going to give a heterogeneous particle distribution. And then the last point I wanted to make was, despite the theoretical advantages of using the inhaled approach with corticosteroids in horses, then one of those theoretical advantages is less drug absorbed systemically, and the way that's often measured is adrenal suppression. So looking at serum cortisol levels after drug administration. And one could argue, well, that's unlikely to happen if it's all going into the lung and it's having its effect in the lung compared to something that's administered orally or intravenously or intramuscularly. But the reality is that the inhaled medication, and this is a study, again, an old study by Bonnie Rush, looking at the use of beclomethasone at different doses and looking at serum cortisol concentration after the administration of those doses. And we can see the top line here is a placebo, and then we have a low dose, and then some medium doses. And we can see there's a dose-dependent suppression of serum cortisol, which clearly shows there is systemic absorption of those inhaled medications that are resulting in a level of adrenal suppression at doses that are therapeutic. So these aren't massive doses that are administered to those horses. These are doses that are used to suppress inflammation within the lung in a clinical setting. This study, interestingly, I've alluded to this when we talked about the clinic or the modified clinical score. So this was work that was conducted in Montreal, and again, looking at the use of cyclosinide and dexamethasone and comparing the two. And again, instead of looking at lung function here, again, we're looking at serum cortisol levels after drug administration. And the dark black bars here reflect cortisol after dexamethasone administration. We can see starting off here, and then dexamethasone clearly suppresses blood cortisol levels, again, consistent with systemic absorption of the drug. Now, that dexamethasone was not given by inhalation in this particular case, so that would be fully expected to get that level of cortisol suppression. But what's interesting is the cyclosinide drug did not, at any of the doses used, suppress serum cortisol levels, which, to the best of my knowledge, is the first time that's really been shown in horses to have an inhaled corticosteroid at therapeutic doses that does not suppress cortisol or suppress adrenal function.
That's good. Just one question, because you talked about if we're worried that we won't have, there's a great variance in how much drug will actually reach the site that it's supposed to go to. Mm-hmm. And so you said then you can up the dose, but there's a dose-dependent systemic effect.
Yes.
So that's sort of the caveat here.
Absolutely, yeah. You have to weigh one up against the other, really.
Yes.
Yeah, absolutely.
Okay.
And it comes down to the efficacy of the drug, but also the method of aerosolization of the drug. You know, is that method of aerosolization more likely to result in higher deposition within the lung? And there's a variety of methods that are available.
Mm-hmm. Talking about treatment with the corticosteroids.
Yes.
Is there still a reason or evidence that we should be concerned about the risk of laminitis in horses?
Yeah, I mean, I think certainly that there is this stigma associated with the use of corticosteroids in horses. And I think theoretically you can see an association between the two on paper. The reality is that borne out in the evidence. I think it really comes down to a couple of issues. One is the potency of that corticosteroid. So which steroid, one steroid does not equal another steroid.
Exactly.
And this was some work I'm just showing here. This was looking at the use of oral prednisolone, and this was work coming out of the UK. And this is a Kaplan-Meier plot here looking at non-occurrence, if you like, of laminitis in a cohort of horses, either receiving the prednisolone treatment or the control population. So we can see that, if anything, the horses in that particular studied group, and there were large numbers of horses that received the prednisolone, were actually seemed to be a lower risk, or they developed less laminitis than the horses that did not. So one feature is that the nature of the corticosteroid. I personally would not have many concerns at all putting a horse onto prolonged, sometimes high-dose prednisolone treatment. I personally also would tend to discuss the potential risks with the owner and make them clear on that, because if you don't, somebody else will, and it's as well coming from you what you feel the risks are and what they are not. And I think when you think about risk in that kind of scenario, you also have to think that laminitis, there's a number of features that will increase the susceptibility of horses to laminitis.
Underlying diseases,
underlying
like
diseases.
EMS and PPID,
exactly.
which you could test for before
absolutely, yeah,
initiating treatment.
Indeed.
And then weighing not the pros and cons of
that's right. Or at least giving some kind of semi-quantitative assessment of risk for that particular horse. So the advice you might give to, a fit warm blood, might be quite different to what I would give to a little fat Shetland pony that's had recurrent history of laminitis. So I think you take each case on a case-by-case basis. But I think that risk is kind of well publicised within the equine literature and within the lay press. But the reality is there's not a huge amount of evidence there, objective evidence, to suggest that it is a real risk.
Okay. Well, we talked a lot about the treatments now, and they have pros and cons, all of them. So in the perfect world, what would the ideal treatment look like to you?
The ideal situation would be that one can change the environment such that the horse no longer has exposures to the inciting antigens or agents. The reality is, firstly, that's often not possible to achieve that. Secondly, even though objectively one can appreciate or measure an improvement in lung function in as short a period as 3 or 4 days after environmental change, the reality is that in severe equine asthma cases, that can take several weeks before those horses will return to baseline levels. So under those circumstances, we often do have to resort to drug medication. Now, I'm taking out the equation those horses that are in crisis, the ones that require immediate bronchodilation to relieve that respiratory crisis that they're in. So I'm largely talking about drug therapy that would have an anti-inflammatory effect, either in the presence of environmental challenge, or much preferably while one is waiting for the response of environmental challenge to take effect. So in that short period, while changes are being made to the management of the horse. So that would be the ideal environmental change. With regard to the drug itself, then this really would be the ideal. So certainly there's many advantages of delivering the drug, and I'm talking about anti-inflammatory, so corticosteroid drugs here, delivering them directly to the site of inflammation. So delivering by the inhaled route, provided that efficiency of delivery is high and appropriate. That drug has a high receptor affinity for the glucocorticoid receptors. So generally speaking, different corticosteroids will have different affinities for that receptor, which is generally measured against the affinity of dexamethasone. Thirdly, that they have prolonged retention time within the lung. So when they're delivered to the lung, that they remain in there or they're recycled in there for a prolonged period of time, again, thus reducing the frequency of dosing that's necessary in those cases. And lastly, having low oral bioavailability, which theoretically in horses, because they're obligate nasal breathers, is not as much of a concern as it is in humans, where they're taking their puffers usually through the mouth. But ideally, one of the reasons for going for the inhaled route is to minimize systemic exposure to the drug.
Definitely.
So that would be my ideal anti-inflammatory medication for those cases.
Okay, thank you. So you work with equine asthma for a number of years,
yes.
20 years or so, right? Do you think that equine asthma is sufficiently recognized as a cause of reduced performance?
I think the severe form of the disease absolutely is. And what practitioners maybe watching this webinar who are used to other terminologies for that disease, where they think about recurrent airway obstruction, COPD, heaves, would fully recognize that the amount of effort that horse is putting into breathing, clearly its performance is going to be reduced. Mm-hmm. I think what we now have to recognize is bringing into the fold those conditions that were previously called small airway disease, inflammatory airway disease, bronchiolitis, all those cases that come into under the umbrella term of equine asthma, under the nomenclature now of mild to moderate equine asthma, absolutely have an effect on performance, and I think probably are under-recognized, yeah.
Yes, because do you think that horse owners are aware that a cough in a horse means something?
That's an interesting question. No, I don't, because the cough is there for a reason. So the cough is a protective defense against inhaled agents into the lung. So the lung has a number of defense mechanisms like mucus production, coughing, bronchospasm even in itself would be a defense mechanism. And largely the immunological response of the lung at the cellular level is often in a slightly immunocompromised state, because with the exception of the skin, it's really the only organ that's exposed to the environment, from the minute we're born to the minute we breathe our last. So it doesn't make sense that from an immunological point of view, our lung reacts in an inappropriate way to everything that it breathes in. So it relies heavily on these other defense mechanisms, and one of those is clearly the cough. So when a horse is coughing, in my mind, it either means there's something stimulating those cough receptors like mucus or bronchospasm, or alternatively, the threshold, the sensitivity of those cough receptors is altered in some way, that they're now responding to what should be an innocuous stimulus, such as tidal breathing. But both of those situations tells you there's a problem in the lung. So if a horse coughs, and that cough is prolonged or frequent, or recurrent, I should say, not necessarily frequent, then I would say that warrants investigation.
Yes, because it could just be a horse that is just coughing once or twice every day when they, for instance, go from trot to canter.
Yeah, but again, that transition from trot to canter shouldn't necessarily induce a cough. So if the horse walks into a dusty environment and he coughs, he's doing absolutely the right thing, because he's saying, this is dusty, I've got to get rid of this dust. But if that cough is occurring over a recurrent period of time, or recurring over a period of time, then to me that suggests there's something untoward. If I was having this interview with you and you coughed half a dozen times throughout this interview, I wouldn't be saying, that's quite normal for somebody to cough. That's an abnormality and one that potentially might need investigated. And when we're talking again about the subtlety of the effect on performance in those cases, then that might be the only sign that we see. And if you look at the consensus statement, we don't have that severe breathing difficulty in the mild to moderate form of the disease as we do in the severe form of the disease. So what do we have? We have a reduction in performance in the history. It may well be that horse isn't performing to a level that any reduction in performance would be recognized. And then the next thing we have is coughing. And it may well be in some of those horses, the only indication we have that they have inflammatory changes in the lung or a mild to moderate form of the disease might be a persistent or recurrent cough.
Exactly. So if you were to give a couple of pieces of advice to the veterinarians in our audience today, what would that be?
I think based on the discussions today, I think get familiar with the terminology, be aware of the fact that there are mild to moderate forms of the disease as well as severe forms of the disease that may impact performance. Be aware of the environment that those horses are kept in, and I'm talking about both forms of the disease. Be aware of the changes that can be made to that environment and the methods that can be used to assess those changes, both at an exposure level but also at a clinical level. And I would say get familiar, and this applies to myself as well, get familiar with these modified scoring systems that have been adopted, because without those, I mean, ultimately we're making an assessment of the clinical case, particularly with severe equine asthma, based upon how difficult that horse is finding it to breathe. And without the advantages of having portable lung function assessing equipment, then it really comes down to clinical scoring. So the more skilled we get clinically at using those scoring systems, then it gives us a yardstick against which we can measure improvement. And that's exactly what would be done in human medicine, along with frequency of use of medication. And then lastly, consider the appropriate therapeutic approach to those cases. Be aware of the central role of inflammation in disease. That yes, there are consequences of that inflammation that may or may not be dealt with separately, but ultimately, if we're applying a drug approach to those cases, really corticosteroids or potent anti-inflammatory drugs, of which corticosteroids is the most potent, available would be the drug of choice. So really, bronchodilator monotherapy in horses now is really not indicated, and that certainly applies to human medicine as well. That's been taken off the GINA guidelines. The bronchodilator, or the use of beta agonist bronchodilators as a sole medication for people with asthma is no longer indicated.
Okay. Well, thank you for the interview, Scott. We will now proceed to our live Q&A session, and we'll see what our audience has written in the chat boxes and answer their questions.
Okay, thank you very much.
We were supposed to be in Amsterdam in the studio, so due to the corona situation, we're broadcasting from the comfort of our homes. And so that's not going to stop us, but sorry for the inconvenience. We are ready to dive into the questions. So the first question, Scott, is about hay steaming. And I'm pulling them a little bit together here because there are quite a few of them. When you steam the hay, do you get rid of the mold/dust? And how long do you need to steam the hay? Is bathing hay overnight also good for getting rid of those molds? And is there a minimum temperature needed?
Okay. I think there's a couple of points here, really. I think the first thing to remember is what we're trying to do when we either soak the hay or we steam the hay. So if we deal with soaking first of all, then really the purpose of soaking is to effectively stick the particles, those particles that would otherwise become airborne, to the hay. So effectively what that does is when the horse is eating the hay, during that process of pulling it from the hay net, those particles are not becoming aerosolized. So that's really the purpose of that. So with regard to the duration of duration of soaking, then the rule of thumb really is that the entire segment of hay becomes soaked. So what we would tend to recommend when we're soaking is to soak the hay net rather than the bale. The problem with soaking the bale is that the outside of the bale becomes wet, but the inside of the bale does not. With regard to the time it takes, then there's been studies looking at even 10 minutes soaking would be sufficient in a loose hay net to significantly reduce the particle load in the horse's breathing zone. So that's really what soaking is designed to do. And therefore, it goes without saying that if we soak a hay net and we let that hay net dry out again, then the fact that it's been pre-soaked is of no advantage to the horse. Indeed, it's probably a disadvantage because you're effectively running the risk of increasing mold growth on that damp hay. And after the soaking. So you're talking about soaking it and then feeding it directly to the horse. So some people would adopt an overnight soak, some would adopt a period of 10, 15, 30 minutes prior to feeding that net. One of the disadvantages, I guess, with regard to the soaking of the hay is you're not sterilizing the hay. Like I said, all you're doing is sticking those particles onto the stems of the forage and stopping them becoming aerosolized. With the steamers, one of the main advantages of the steamers is that it does result in sterilization, and those commercially available steamers, they do reach high enough temperatures that they can get a significant reduction in bacterial count in the hay that they feed, and therefore when they dry out, then again there's less risk of those then growing a significant mold on them after drying. But they usually, again, they're going to be fed within a relatively short period of time after the steaming. Going back to the soaking, again, if you're using a single bucket to soak them in, then clearly the effluent within that bucket is going to be pretty nasty after one or two soaks. So we would always advocate using fresh water for each of those soaks. And I guess one last point that I would make would be with regard to the nutritional quality of the hay. There's a couple of studies out there quite clearly showing that the longer the hay is soaked for, then you have a reduction in those soluble carbohydrate components of that hay. So the nutritional value of the hay will be affected with a long-term soak, which used to be seen as a disadvantage. It may actually be an advantage in some horses that are looking to reduce their carbohydrate intake. So steaming hay, soaking hay, both have their advantages. Some have their disadvantages, but ultimately, from the point of view of improving airway health, it's really just a case of sticking those particles to the hay. So hopefully that answers the question.
Okay, thank you. Then there are a couple of questions regarding bell. There's one here. Would you prefer bell, or is a tracheal aspirate during the endoscopy good as well? And is there a difference in cytology between the two methods?
The answer to the first question is yes. If a BAL is feasible and possible and deemed safe and appropriate to conduct, then by far the information that you get from that, now we're just keeping this discussion around the subject of asthma, the information you get from that is, in my opinion, certainly a lot easier to interpret with regard to the inflammatory cell ratio in the cytological picture that you get from the analysis. So there's been work conducted that's quite clearly shown that when you're looking at correlates between histopathology in the lower airways and BALs, then that correlation is significantly better than it is between the histopathology in the lower airways and a tracheal wash sample. So if a BAL is possible, then certainly I would take a BAL, but that's on the assumption that you're dealing with a diffuse lung disease, because obviously when you're performing a BAL procedure, you're isolating one segment of lung and you're making the assumption that the cytological data that you obtain from that segment of lung is representative of what's going on globally within the lung. So I would say a tracheal wash has an advantage when you're thinking about horses perhaps having localized lung disease. So the lung abscess or localized pneumonia, where if you blindly performed a BAL procedure in those horses, you could quite easily lavage a segment of lung that was relatively healthy. Whereas you're more likely to pick up those abnormal cells in a tracheal wash cytology. So the trachea is effectively, it's like the sewer of the lung. So, cells come from everywhere within the lung up that mucociliary escalator, ultimately become swallowed. But the downside of that is that there's a significantly more variation with regard to the inflammatory cell profile within the tracheal wash. And also the quality of the cytology is not nearly as good. It's not nearly as easy to read a tracheal wash cytology sample than it is a BAL. So from the point of view of asthma, on the assumption it's a diffuse disease, a BAL, because of the correlation and because of how easy it is to read the slides.
Okay, so I actually have a question here on the safety of doing BAL. One is asking, when the respiratory effort is increased and the amount of mucus is excessive, would you still feel that it was safe to do a BAL?
I think that's a really good point. I saw that question when it came up during the webinar. I think it's a very valid point. It really comes down to your own clinical judgment. I totally agree, and there are certain horses where I have not proceeded to do the BAL because I feel that the benefits of that procedure are outweighed by the risks associated with that in a horse that has a significant level of airway obstruction. So that's point number one. The other point is, well, you could argue, well, okay, it's contributing towards, it's an important part of your diagnostic workup of those cases. But as we alluded to in the webinar, it's a marker of disease. So the BAL is largely from the severe form of equine asthma, which is the form that we're talking about when you're concerned about those horses being very heavy. So we're kind of taking the mild to moderate cases out of the equation here. With those severe forms, really what you're trying to do is to recognize the presence of neutrophils within the sample. The actual number of neutrophils doesn't really correlate necessarily with the severity of disease. It's how heavy the horse is. So you've already got that information, a lot of really important information before you even undertake that BAL. And there's certain anecdotal reports as well of horses having what we would term polygranulocytic form of severe equine asthma. That is to say, they are severely heavy, but in actual fact, when a BAL is performed, they have a relatively low number of airway neutrophils, and the reasons behind that we're not quite sure. But one theory is that in actual fact, when you do a BAL in those horses that have severe lower airway obstruction, you're not actually washing the lower airways. You're just washing the upper airways. So it's not really reflecting what you see on the slide. Doesn't necessarily reflect what's going on down at the terminal airways because your fluid's not actually getting down there. So, so a number of reasons why you could justify not performing a BAL in a severely heavy horse. But I think by far the justification that carries the most weight would be the welfare of the animal.
Okay. On the topic of the BAL, is it necessary to analyze the sample the same day as it's taken? I know that can be a challenge in some countries.
It's preferable. That I think as soon as we take those cells away from their natural environment, then the quality of the cytology diminishes somewhat with time. And I think, going off on a tangent a little bit, this is possibly one reason why the quality of the cytology in a tracheal wash sample is not particularly good compared to a BAL, because those cells have come up. If you're looking at the macrophages, you're looking at the neutrophils, unless we're dealing with tracheitis cases, most of those cells are on their way up the escalator from the lower airways. So they've kind of done their job and they're moving up to be swallowed or coughed out or whatever. But going back to the question, then yeah, absolutely, over time, the quality of the cytology does diminish somewhat, but there are ways around that. So my advice would be to contact the lab who looks at those samples and does the cytospin preparation for you, and ask for them to send you some form of cytoprotectant that you can dilute your sample with. Another thing that Kirsty Dacre found, she did some work in Edinburgh a number of years ago there, looking at different influences on bowel cytology, and we found that actually sometimes adding a little bit of autologous serum to the sample can preserve the cytology as well. So taking a blood sample of the horse, allowing that to clot, spinning that down, and then just adding a couple of 100 microliters of serum to your bowel sample, that seems to help with the cell preservation as well.
Okay. We have a question actually on if you have a special treatment plan for horses with a high percentage of mast cells in their BAL.
A high percentage of
mast cells.
Well, mast cells. Yeah, that's a good question. My approach to those ones is initially looking at the environment of the horse. I think when you look at the studies that have evaluated the cytokine profile of those horses with the metachromatic or the mast cell form of mild equine asthma, and they've been looked at as a standalone cohort and not lumped together with the neutrophilic ones. And you look at the cytokine profile, then, you know, if you look closely, it seems to be much more consistent with a hypersensitivity or an allergic type response in those horses. And therefore, I think it adds credence to the fact that the environment probably does play a role in those cases. Now, personally, I've had experience of a number of cases that just an environmental change, sometimes quite a radical environmental change, has been necessary to resolve those cases. If that's not possible, then again, I would reach for the steroids as a first therapeutic line of treatment. And if that failed, then you might start thinking about some of the chromones, inhaled chromones in those cases. But by far the majority of cases I would treat with environmental control, so trying to identify what the inhaled allergen might be. Well, not the specifics, but, you know, is the management of the horse such that it has got a high exposure to organic dust? Try and resolve that. And from a therapeutic point of view, steroids.
Okay, I have a couple of questions on the clinical scoring system. One of them is, which system was used in the study that you talked about to mirror lung resistance? Is that
okay?
Specific one?
When they looked at the correlation with lung resistance?
Yep.
Yeah, it was a modification of a scoring system that was initially developed by Tesarowski. It's fully published, and they were looking at variability in lung function and scoring or clinical scores using that scoring system when horses were in disease exacerbation and remission. These were horses with severe equine asthma. So it's largely based on that, with one or two adjustments made to it. And that in itself was based on a scoring system that was developed a few years earlier by Andy Hoffman. So it's well established. And I think the advantage of that scoring system is it uses a number of different criteria in order to reach the score. And it seemed to, I mean, encouragingly, the correlation with the lung resistance gives you some kind of assurance that when you apply that system, albeit a little bit more hassle than just observing the horse breathing, then you're much more likely to come up with a kind of accurate semi-quantitative assessment of that horse's severity of disease. I know that a simpler system would be just to look at abdominal component to breathing and nostril flaring and coming up with a score based on just those two criteria. And that's been used in a number of studies as well. The problem is it's not hugely, I mean, horses tend to have to be quite severely affected before you start to see a significant increase in that score. Yes. And then lastly, the other scoring system that some of the viewers might be familiar with was the one developed by the group in Bern, the Horsey system. So this is a horse owner assessed, if I get this right, respiratory signs index, so a Horsey system, which is based partly on historical information from the owner, and that's been used in some of the large genetic studies. But I think on an individual horse basis, and looking at that data on the correlation with lung resistance, then I don't know if there's much out there that would beat that modified Tesarowski scale.
Yeah, and it's practical, more practical to use.
Yeah, absolutely.
We're almost out of time, but there's one question that I want to ask you, because I know that we've been asked this a lot, and I hear that amongst colleagues. And this is a case that we see from time to time. A horse is presented coughing 2 or 3 times in the beginning of exercise, but has no other symptoms, never coughs at rest, and has no apparent decrease in performance. How would you continue the diagnostics with this horse?
Well, I guess the first thing is to make the decision in your own head as to whether you feel that that horse's cough is indicative of a problem. And as I mentioned in the webinar, in my opinion, it's not normal for a horse to cough at the beginning of exercise. You know, if I went out on a run and I coughed for the first 50 yards, then I would think to myself, well, there's something not right here. So that's one question. Is it normal or isn't normal? Now, that's a different question to determining whether it's affecting the horse's performance or not. When you're looking at an individual horse, it's different if you had 100 coughing horses with that kind of mild presentation and 100 horses that did not cough, then you might be able to determine whether there was a performance limiting effect of that. But on an individual horse basis, I think that's another question that has to be addressed. And both of those questions really are ultimately going to determine whether, you know, further diagnostics are indicated. So for some people, the very fact that it is coughing, and if you agree with me, you may not agree with me that is not normal, that would be enough for some people to say, okay, we have to try and investigate this and see if we can resolve this. For other people, they might have the attitude, well, the horse is coughing. I accept the fact that that's not normal, but you know what? The horse is doing what I want him to do. So there's a number of factors that will determine whether further investigation proceeds. But in my hands, if I did decide to proceed with investigation in those cases, which I probably would, then the likelihood is your clinical examination alone is not likely to yield any particularly exciting results in that particular case. So if you think about what the potential cause of the cough would be, then we know that it's likely to be involving the airways. There might be some upper airways, some laryngeal issues. There are a cluster of cough receptors around the larynx, and then the trachea is pretty much devoid of cough receptors, and then they start to increase in numbers as you get to these large branching airways. So assuming there's no laryngeal problem in that horse, then the obvious place to go is the airway. And the obvious thing to do is to sample the airway. So a BAL, again, would be indicated, endoscopy would be indicated, and look at the cytological profile in that particular case and see if it's abnormal or not. That would be my next step with those cases, on the assumption that the physical exam didn't yield any exciting results. What you sometimes find with those cases, though, is that an examination at rest doesn't yield anything particularly exciting, but when you put a rebreathing bag on the horse, then you can sometimes induce quite a significant cough in those cases. So effectively what you're doing there is you're just increasing the turbulent airflow and the velocity of air during tidal breathing. So akin to what they're doing at exercise. And if that induces a cough, then again, I would attribute some significance to that.
Yes. Thank you, Scott. I think we're out of time, and I know that there are more questions. I think we will try to answer some of them in writing afterwards, because we don't have the time to go through all of them. And otherwise, I encourage you to reach out to your local Boehringer Ingelheim consultants. We'll do our very best to answer your questions. So I think I just want to say thanks a lot, Scott, for joining us in Amsterdam and also here tonight. And thank you to all our viewers. We're happy that we're able to do such a big gathering in these times and do it online. So thank you.
Thank you very much, Charlotte.